it's important now to think about how PIRA happens, and I'll show you what that means. But in ideally, it's about 80% of people who had a disease for 30 years or more will have those lesions active in 80% of their spots. So if you look at your MRI, and those MRI that look stable to people, when you actually take them 20 years, 30 years in your disease, they're all still active, but you can't see it. You can't see it on the MRI we have. So now we have a technique in MRI. It's a new thing that I hope that it will be available for us to look at. And they found that these cells, remember those vanguards, the rim of things that can contain MS, those have iron in them. And now they look at a new technique to see if they can see this iron. And by the iron being available, we know that this is a chronically inflamed lesion. And if we look at that closely, we then can tell how many of these patients are truly active. Are these patients having disease activity, or there's none of this disease activity? And then, because we have ways to monitor this and to help it, this is a cross-section in the brain of an MS patient. And you can see this is the blood vessel. And all the shade of light white, this is myelin B loss. And it's not only in the lesion, which is here, but all the way deep. You see the inflammation has happened and the myelin is lost. All you can see in MRI is this guy here. You don't see the depth of it. It's like a tooth, very similar to a tooth. Because in a tooth, you just see the carotis up there. But how deep it is and what the damage is causing, you don't see that. We have now deeper slices in MRI that, again, these are non-commercially available, and it takes a lot of work for somebody to read them. But you truly, if you have that capacity, you will understand why MS and MS imaging are not concordant. All right, and when you stain these cells, you actually see a lot of these cells we call microglia. The cells that we, until today, don't have a good medication to work on. We fancy name for them, we call them CD68s. So these are the cells that are actually the garbage trucks. They come and their job is to clean the debris of a battle and to engulf any foreign body. Those eat myelin away. And we don't have a single medication, or at least we haven't targeted them because we didn't know that they're part of MS. We truly didn't until very recently. So that's why the whole focus now is to do this, to focus on these cells. These are just different ways to look at them. This is the way we see them on a new MRI technique. This is the way we see them under the microscope. So that's the name for them. We call them paramagnetic rim lesion. And I'm just going to back here so I can read you some of this. So it's a new concept. Hopefully, if we have that available, we will be able to tell about patients with higher disability. Interestingly, those are patients also, if you do their lumbar puncture, they have higher oligoclonal bands. Because in the past, we didn't know what's the relationship between MS activity and the number of oligoclonal bands. We just knew that patients who have more than 10 bands will do worse. We just didn't know why. And these are now, we are developing new MRI techniques to look at them. So hopefully they will be within the future of MS. In addition, we are looking at the number of lesions and the brain atrophy, like Lindsay was saying about the shrinkage of the brain. Now, we don't know why shrinkage of the brain happens in the first place, but we think as we grow older, our brain shrinks because cells die. Well, it turns out that in MS, the inflammation also kills the axon, which is the main feeder, the provider for the house, if you wish. So the cell behind it dies eventually. And that's why you lose more and more cells, and the brain shrinks faster. So this is another picture. This is another study modality that is kind of a good visual. This is a scan we call PET scan, which is usually not used in MS that much. But it tells you, this is a special PET scan that can look at these microglia and tell you if they're active or not. So this is the brain of somebody who's healthy and doesn't have MS, and you can see there are not many red spots around. And this is patients who have relapsing MS, and you can see that there are a few red spots. But look at this progressive MS, the secondary MS. There's a lot of red spots. These cells become really active. in progressive MS. And we think that these are the ones that are driving disability in people who don't have relapses. So these are the new targets in multiple sclerosis, or at least it makes sense to target them. And now we have some biomarkers also to look at the function of these cells. So there's something called NFL, neurofilament light chain, which has been associated with progression, level of disability. There are many clinics in MS now that use these blood tests because they can help you in a way to see if your patient is progressing, has progressed, because these live within the axon itself. So when you release them, when they're released, that means they're no longer in the axon, which means the axon has been destroyed. So when you see higher levels, that means more destroyed tissue. And there are multiple other biomarkers that we're looking at now, and their combination will help us to understand a little bit about MS. Some of those are inflammatory, some of those relate to degeneration, like these guys, tau and amyloid. These are basically also used in Alzheimer's disease, because Alzheimer's disease is another degenerative, not necessarily immune, although there is inflammation in Alzheimer's as well, and in Parkinson's, and in all these diseases. People didn't used to recognize them, but there's a lot of inflammation in them. It's not the primary problem, but the immune system has to intervene when there's damage. So now there are people who are looking at Alzheimer's and Parkinson's from another end. Can we interfere with the inflammation of those diseases? Can we slow it down? We come into MS from a different end. We started with the inflammation, and now we are looking at degeneration. So the new thinking about MS is to try to find a new medication that target those cells that we just spoke about. And one of the thoughts are BTKs that we just mentioned. This is just a group of medication that contain enzymes that are very important for the survival of these cells, in addition to the other cells we call B cells. So BTK is one of those pathways that I think now multiple studies are looking at it, and hopefully we'll know more. Would it be the answer? I don't know. Would it have hope for the future? I think so. But at least we have answers to our questions. This is a complex slide. All it tells you that these medications hit different areas in the immune system. The target is the same, is to stop those smoldering lesions. And there are a few of them that we are looking at. They're different in name and their characteristics, but similar concept to all of them. And there's a new concept also to look at a new molecule we call CD40 ligand. And these are now the cross-talking between the immune cells. See, the immune cells, we used to learn immune system as in their B cells and T cells. This is not the way it is. They're all in the same trench. They all talk to each other. And by talking to each other, they cause inflammation. So now people are also trying to target the messaging system between them, to disconnect them. Now, don't think that will be without a price. This might prove to be costly. But again, we're trying to find something that is safe, and we're trying to find this midway home between treatment and protection, especially because in MS population, we're targeting a more advanced in age. So the risks are higher. The treatments are more difficult. This is a topic that I get asked about. What about stem cells? So what are stem cells? You know, it's a very common question, right? Everyone who sits in your clinic, can I get stem cell? Because the hope that in our patient's mind, that stem cell is something that's going to go in and just replenish your immune system and you'll be bionic 5 again. Well, that doesn't happen. Stem cell therapy at this moment in time are very strong reconstitution therapy, which means that you wipe out your immune system and you start from the beginning, hoping that the new kids on the block will be wiser than their ancestry and they wouldn't attack you. We're not at the stage yet that there are cells that come and repair. Because imagine this, there's a myelin, and beneath the myelin there's the copper wire, the axon. Very early in the disease, you attack the myelin, you take away, but you also damage the axon. So what's the benefit of putting the tape back on again after 15, 20 years? It's not going to work. So you need a new concept. Now people think that remyelination has to happen during the first MS relapse. You shouldn't wait until the patient can't walk anymore or the patient is blind. It doesn't work anymore. The wire is cut. And that's, I think, a hope for the new generations with MS, that we have that understanding. Unfortunately, education is very lacking in MS. When we see the young new patients, they don't want to be treated. You know when they wanted to be treated? 30 years later when things are very bad. And that's the problem. I think that is why education is important in MS. Because if you don't catch it that early and you don't advise those kids to get their own treatment and help themselves, you say, look, if you come to me 10, 15 years later, I probably wouldn't be able to help you. And unfortunately, we live in a world that, Dr. Google is there, there's a lot of blogs, you see a lot of things, right? So when there's a patient sitting in your clinic trying to argue that this is not MS, but black mold or a toxin that they had, you have to respect it. But again, you say, look, I probably saw more MS patients that you have. So I know the story. I know when I see it. One of my mentors says, I don't know what I have, what you have, but I can tell you for sure you don't have MS because I know MS when I see it. And I think that's probably because that repetition in the pattern makes you a little bit more acquainted with the disease and you know how it behaves. That's why we get concerned about certain of patients when you say, oh my God, this one will not do good. That's why we have to hit it hard from the beginning. We have to be aggressive. Because the second thing you know, they're coming with permanent disability. They're dragging a leg a year later, or the hand doesn't work anymore. Do you think we can fix that? It takes a lot of time to fix this, if you can fix it, but it's much easier to prevent it. So remyelination, as I said, it's a concept that's now happening, and yes, I think I'm coming to an end. But remyelination, if you want to think about it, you have to do remyelination early, and there are many studies now in the UK and in Europe that's doing remyelination very early in kids. Actually, there's a study in London that's looking at remyelination in pediatric MS patients, and it's happening during the first attack, which I think will be a good niche for these patients. And mitochondrial dysfunction is what I'm going to finish with. Mitochondria are the houses of energy in our body. And these are for patients with progressive MS are very important reasons to why they get fatigued and their muscles are deconditioned. So there are now new thoughts about if we can't fix the myelin and the nerve, can we at least recondition the muscle in a way that doesn't get that fatigability? It doesn't tire out very quickly. And I think this is going to be my last slide. In MS, we're trying